I'm really excited for what's going to happen today. First, Gabriel is going to be facilitating, and he's awesome. He always makes my day, so I'm really excited to see that. But I'm also very happy to introduce Promise. You might have met her already in some of the previous VMRs. She presented a case for the Women DX VMRs, and she's overall a very enthusiastic and incredible medical student. She's going to introduce herself, and she has like a really fun question for everybody.
Hi, everyone. I joined Solvers. I really started going to VMRs in end of May, and I think I just like got dragged into a dark hole. And then today is my first time ever scribing, so be nice to me, and I definitely will need everyone's help here. And then my question is, what is everyone's favorite McDonald's country? And I can start. So I actually grew up in Hong Kong before moving to the US. And I think while I feel like the menu in Hong Kong is pretty similar to the US, I just liked how the portion size is a lot smaller and is more flavorful. I think that's the biggest difference that I noticed.
Well, I think my favorite kind of McDonald's here in Peru is, actually, I don't tend to go to McDonald's so frequently, but when I go, I go to a very near McDonald's that is like approximately 1 kilometer to my home. So I usually like to order some crispy chicken. I really love it. And also about talking about fast food, I do love Kentucky Fried Chicken. How about you, Maria?
Yeah, I actually went to the most beautiful McDonald's in the world, and it was really nice. Like it had chandeliers, it had like mirrors in the ceiling. I'm not gonna tell you where it's at, but it's not Brazil, it's not Japan, it was not India. So like trivia prompt, where do you think the most beautiful McDonald's in the world is? And I'll let you know. But I do love fast food. I love I love it, all types. Trying to become a pescatarian has made it a little bit harder. But yeah, Rafa, what about you?
I was discussing earlier that I actually don't go to McDonald's that often, just like Gabrielle. When I go, I actually go to eat ice cream because I love their ice cream. And when I want to eat some fast food, I actually go to the Subway because they have this various type of salads, and I can pretend myself that I'm a little bit healthier. So what about Robbie?
Hello, good morning, everyone. I was a McDonald's junkie as a kid. I had so much McDonald's. It was really bad. I partially felt a little bit better because I would run around a lot on the soccer or football field. And it's amazing how, in many ways, coming to the US, to the origin of fast food, was a major disappointment, because McDonald's here in the US compared to anywhere else I've been abroad sucks. It's so bad. I had McDonald's for the last time in my life, I think, in San Francisco, where I felt like I was eating cardboard. It was so bad. But McDonald's in Lahore, Pakistan is just unbelievable, because there's a little bit of a local spicy twist to many things. And I can't tolerate much spice, but a little bit of pizzazz in your food goes a long, long way. So I remember there was a sandwich called the Muck Arabia sandwich, which I think is only a local delicacy. And it just was like spicy chicken and like some local sauces and whatnot. So you got me real hungry now. But yeah, McDonald's in the US compared to anywhere else abroad. Yeah, Fernando, you've had the Muck Arabia. Amazing. Yeah, so I wish you many McDonald's, but not here in the US. I think everyone, oh, actually, Emery, do you want to say hi?
Hi, everyone. Happy Saturday. I don't have McDonald's very much as an adult, but near my apartment in med school, there was a McDonald's. And so as a dessert, I would get a chocolate dipped ice cream cone, and that brought a lot of joy. And sometimes I do have like cravings for just a really bad double cheeseburger, and I would get that too. And I'm going to pass it on to Gabrielle, who will be facilitating today.
Well, thank you so much for talking about each other favorite fast food. I think we're getting know about each other. So we're looking for one case presenter. I think, oh, Rafa has a case. Awesome. So Promise, can you share us the whiteboard and let's get started.
Okay,
Whenever
so
you're ready, Rafa.
yeah, I was just waiting for Promise. So we have a 50-year-old male with leg pain and weakness. And that's the end of the aliquot number 1.
Wow,
by the way,
very
this
interesting.
is by the way, this is a human Jack's case by Heather Corrigan.
Well, very interesting, Rafa. Leg pain and weakness in a 55-year-old patient. So we'd like to pass 1 minute, and in order to put our ideas together, and I'll be highlighting the comments on the chat. So I think Fernand has ideas about how to localize the pain. Fernand, can you share with us what are you thinking?
Yeah, hi everybody. So I generally approach limb pain, be it leg pain or arm pain, by trying to get a feel of the description of the pain. Is it tingling, burning? Is it sharp? Is it where it is localized? What exacerbates it? Is it movement or nothing specific? And try to, based on the description, to narrow it down to either the muscles, the joint, the bone, or the nerves. And sometimes it's more tricky than you can imagine.
Yeah, I highly agree. It's sometimes very tricky to try to localize what is the structure compromising the leg. And also Emery has like idea about how to connect a weakness in this chief complaint. Emery, can you share with us?
Yeah. When approaching weakness, I'm just going to be thinking about, is it a proximal weakness or a distal weakness? And is it unilateral or bilateral? Because certain diagnoses like myopathies a lot of times are usually proximally, whereas other things it could be more distal, like especially a neuropathy or an ischemic disease. You might see more distal involvement. And then like if it's bilateral, I'm definitely thinking about a more systemic involvement, like a myopathy. If it was unilateral, I might think more about like an infectious etiology or some other etiology like a DVT or something that could occur just on one side, or like diabetic myonecrosis or something like that. And then the onset and progression of symptoms would also be a really important clue, like whether this was a more slow, insidious process versus a really rapidly progressive process.
Thank you so much, Marie. I think also Ravi has like a nice idea about the red flags of leg pain. Ravi, can you share with us?
Sure. Hi. I always like to start with any problem thinking about what could be the worst kind of conditions that sort of create an emergency. So one could be trauma, crush injury, so like a rhabdomyolysis, acute limb ischemia. Somebody mentioned, I think Anne-Marie mentioned, if there's a synovial Q to the leg, any sort of inflammation, abscess, infection, septic arthritis. or something as grim as compartment syndrome. So a couple of really malignant sort of conditions that we must think of before we break it down, like some have described anatomically.
Thank you so much, Ravi. I think it's highly important to recognize there are some known missing diagnoses that we have to keep in mind and rule out in order to save the patient. And Daniela, I think you have like a very interesting question about the tempo and its importance in trying to elaborate on this shift complaint. Can you share with us your idea, please?
Oh yeah, hi everyone. Good morning. I think that it is important in every patient, especially someone who presents with pain or weakness, to see how long these symptoms have been happening. So for example, maybe he has had this like pain and weakness for a long time and it has progressed over the years or months or weeks. Or maybe it could be an acute cause of like pain and weakness, and that can help us rule out any differential diagnosis that don't quite fit into the picture and on how it is presented. Yeah.
Daniela, your semiology is on point. Thank you so much. Rafa, I think we can hear you more about the history of present illness.
Okay, so this patient had a 3-month history of progressive left lower extremity pain and weakness, causing difficulty ambulating. He initially also had a painful purple rash on his lower extremities, along with the numbness, which spontaneously resolved after 1 week. There was a progressive functional decline associated with peripheral paresthesia and weakness, causing increased difficulty with ambulation for 3 months prior to admission. He was seen by outpatient neurology on the day of admission, who recommended urgent ED evaluation. And one month before the above symptoms, he was hospitalized for a typical pneumonia. And that's the end of the aliquot.
Wow, I wasn't expected about the palpable rash and also the past medical history of pneumonia hospitalization. I would like to take a little pause in order to put our ideas together. I think Ravi has also made a nice pair about palpable rash, thinking about vasculitis. Can you share with us that, Ravi?
Oh yes, vasculitis, I guess commonly, I was working on a schema for this for purpura. Vasculitis tends to have a palpable sort of morphology, but non-palpable purpura, you can have any number of different things that may be non-immunologic. So just a little comment there, or a question about this rash, if it is palpable or non-palpable.
Mm-hmm. Yeah, I think like that's very important because it also could explain also the symptoms of the patient. And also I think Franco has like a very nice idea about asking about their smoking status of the patient. Franco, how can you think about smoking status can explain the symptoms?
Well, yeah, for example, if we're thinking about vasculitis and some lesions in the legs, I immediately think about the possibility of a person who is a smoker and can develop a Berger disease. Kind of vasculitis pretty related to the smoking status of the patient that could present in this fashion.
Thank you so much, Franco. I also think like Jasdeep has like a nice idea about Legionella that could explain these symptoms. Jasdeep, I don't think I've never heard your voice. Very nice to reading your comment. Can you share with us where are you from, where are you calling, and share about what was you thinking?
Hi, can everyone hear me? Can everyone hear me? Oh, hi. I'm Jasdeep. I'm a family medicine resident in Rochester, New York, but I'm originally from Canada and my parents are from Punjab, India. I was remembering a week ago, we had a case of Legionella leading to rhabdo, and Legionella being one of the most common bacterial etiologies for that. The time frame really doesn't fit as well, but it was just another thought. And then I'm not driving. I'm sitting in my car, parked car for now, so I'm not driving. But I just wanted to say that Legionella could lead to this. And then in terms of, I think the Mycoplasma pneumonia is also a really great thought as well, because it can lead to all sorts of rashes as well. But when I first heard of rash, weakness, and pain, I automatically thought about vasculitis first.
Yeah, thank you so much. I think Legionella is one of my favorite bacteria because it can cause a lot of cross reactions in our bodies and also present with arthritis, erythema multiforme, and sometimes it can induce hypersensitivity reactions. I remember we have a case of a young patient with a past medical history of atypical pneumonia, and later he presented with extremely weakness. He couldn't walk, and so the final diagnosis was hypersensitivity reaction due to Legionella. So that is a really nice idea. I also think okay, Ravi, can you share with us if we are on the right track?
100%. I just wanted to reflect with you all. I hope you're realizing this is Gabrielle's first time facilitating, and I'm in awe of how calm, collected, and deliberate he is. It's really a joy to watch. I wanted to add on to Iram's point that she was sort of connecting a rash and pneumonia and thinking about granulomatosis with polyangiitis. And I think that as everyone is suspecting, a vasculitis is something to really think about. And I think that comes with the assumption that the localization is a peripheral nervous system localization, right? You could have a rash and myelitis, you could have a rash and an encephalitis. And so here, my only pause is to make sure the rash isn't a clue for another neurological localization, because it's very easy to have painful lower extremity weakness from a myelitis or a brainstem disease. But I think more importantly, what you're seeing here is the importance of reflecting on vascular involvement of the peripheral nervous system. So usually when somebody has weakness from a vascular problem, it's usually because of a stroke. Vascular disease and the peripheral nervous system have much less overlap. It's much less common to have a stroke in the spinal cord, and even less common to have a stroke in the peripheral nervous system, which is the mechanism we would be invoking if we're saying this person has a vasculitis causing neuropathy, right? So how do you approach the overlap of vascular disease plus peripheral nervous system? And I think the priority here is to exclude a large vessel vascular problem, and then medium vessel, and then small vessel. Because the larger the vessel, the more consequences there are to the body. So the NOMIS diagnosis here is an aortic disease causing embolism to the skin and embolism to the nerves. That could be a bland thrombus, like was mentioned, of Lerice syndrome, but also an aortitis causing embolic disease. The next order of priority is to make sure that a medium vessel isn't causing it, like polyarteritis nodosa or a thromboangiitis obliterans. And then after that is the small vessel. So what are the big themes here? I think the big themes are the world of vascular and neurology usually results in brain problems. Here, there's no brain symptoms, so it's much less likely. Vascular plus any other neurological syndrome is much less common. Spinal cord, unheard of. peripheral nervous system disease like acute limb ischemia or mononeuritis multiplex, very, very rare. But I think here they're the priority. And if you're going to go in a certain order, rule out large vessel, then medium vessel, then small vessel. Why? If you have a little clot in a tiny small vessel, no problem. But if you have a clot in your aorta, much bigger problem. All right, I'll give it back to you, Gabrielle.
What a master teaching, Ravi. Thank you so much. Well, Rafa, we can.
Okay,
Oh, I think I was muted.
Yeah, you were, but I got it. Just to make it less obvious, let's say I'm hiding something important here. Okay, so the next aliquot is past medical history. This patient has frequent sinus infections and hypertension. Past surgical history, none. Medications, this patient is on acetaminophen, ibuprofen, amlodipine, albuterol, and a budesonide formoterol inhaler. Social history, no tobacco, ethanol, or drugs. And this patient is a bus driver. He moved to the US from Ethiopia in 1998. And there is no recent travel history. Other positive revealed system includes 1 month of recurrent night sweats, 1 month of epigastric pain, 3 months of diffuse weakness, and 3 months of unintentional weight loss, and 12 months of intermittent dry cough, unable to breathe out of the nose due to congested sinuses. And that's the end of the aliquot.
Well, thank you so much, Rafa. That is a very interesting case. I think a lot of people in the chat are commenting about some types of vasculitis that could explain all the physical findings too. I think Drew has a really interesting idea about thinking in GPA. Drew, can you share with us the idea? And also we'd love to hear about how are you doing in residency?
Sure. So hi everyone, I'm Drew. I actually had presented a case on Monday. So for those of you who were there, hi again. So there was someone in the chat above had mentioned, in the context of vasculitis that we could be considering something like granulomatosis with polyangiitis, and now, or any of the other ANCA vasculitides. With this patient having pneumonia, frequent sinus infections, and asthma requiring albuterol and a budesonide inhaler, I'm now starting to think, is this GPA or is this eosinophilic GPA? Or what exactly could this be? The only thing is that I guess this may just be me not knowing the illness script of the ANCA vasculitides well enough, but usually when we think about it in the context of frequent sinus infections, and lung involvement and kidney involvement, whereas for eGPA, we think about it as asthma with sinus infections and kidney involvement. I've never actually seen things like the purpuric rash or anything like described in any of the board questions that we get. So just my thoughts, and not necessarily all my own thoughts, but there are some people in the chat who I do not exactly know at the moment or remember at the moment, but they were the ones who started this train first.
Thank you so much, Drew. We love also all your contributions to the amazing community of VMR. I think also Mario has suggested a really nice hypothesis about other granulomatous diseases such as sarcoid and TB Franco, can you share with us what was you thinking?
Well, yeah, about tuberculosis. I recently read a paper about polyarteritis nodosa that shares some epitopes with tuberculosis. So actually, there is a big theory about that. People that has been previously infected due to tuberculosis is the kind of the molecular mimicry, and also later on develops polyarteritis nodosa, that it's a vasculitis that can affect, can present sometimes with skin manifestations also. Immediately I think about sarcoidosis because the nice was because he's from Ethiopia. There could be a link over there. Tuberculosis because the night sweats, the vasculitis rash. Maybe that typical pneumonia wasn't just an atypical feature of pneumonia. It was kind of a pulmonary manifestation of tuberculosis. Tuberculosis is here in Peru is known as something that the great mimicker. Here can be anywhere else, can have sinus infection as well. But I think the most probable cause is, for example, right now is GPA. It's on the top of my list. The other ones I kind of differential that would need more of the laboratories or the exams.
Definitely, Franco. Thank you so much. And TB is also one of the favorite topics in the VMR. I think also Erin has a really nice hypothesis about EGPA. Erin, can you teach us more about EGPA?
Yeah, so hi everyone. I hope you can hear me. So this is my first time with the mic off. I'd like to introduce myself. I'm Iram Khan. I'm also from Ahmedabad, India, and I'm a student in BJ Medical College. Yeah, I was just adding on to what Dhruv mentioned about the EGPA, the Church-Strauss disease, and I think it is also a likely possibility because we have something like a vasculitis picture and the lungs involved. I think I remember, if I remember correctly, I read somewhere that it has a lot of rheumatic involvement in polyradiculopathy, and sometimes it even starts as a Kushal, thank you. So sometimes it even starts with the small joint involvement, like the wrists, and I remember I was reading for my step one, and I saw this case on UWorld that started with the joint involvement, and then eventually it was an EGPA. So I think that is what I would just like to add on.
Thank you so much, Erin, and thank you so much for connecting in from India. Really happy to see how VMR has been expanded to all the places around the world. I think also Daniela has suggested a really nice hypothesis about leprosy. I think leprosy is very common in Brazil, not so much common around the world, but Brazil is one of the main countries with lots of cases. Daniela, can you share with us about leprosy?
Hi again. Yes, I actually had a professor that really forced us as best as possible to learn as much as about leprosy as possible. And what I remember about it is that you can have a spectrum of presentations. So there are patients who are able to form an immune response that is effective against the mycobacterium, and that will lead to lesions that are not as how can I say, it wouldn't spot it wouldn't pay as much attention if you weren't looking for it, whereas some patients who do not have the proper response to leprosy would have presentations that are kind of what I believe you would think about when you think about the disease itself. So I think with this patient, it wouldn't be really my main concern, although the patient presents with paresthesias that are possible with leprosy. I think that someone commented about the possibility of evolving to nurse, but the rash resolved, and it's no longer there. And that is not something that you would expect with leprosy. If you still have any doubts about that and you would like to search more about it, there are tests. The first one would be for temperature and pain, and you will just continue some pressure and then just feeling itself. And you could test that with the patient to evaluate if there is any damage to the peripheral nerves. Yeah.
Thank you so much, Daniela. And I think we can hear you more about the case, Rafa.
Oh, great thoughts. Okay, so now we're gonna go to the physical exam. So the temperature was 38.2. The heart rate was 102. The respiratory rate 22. And the blood pressure 120/89. And this patient saturating 96% on room air. When it comes to the lungs, this patient has few scattered expiratory wheezes. Cardiovascular exam, it's normal. Abdominal exam, it's soft, non-tender, non-distended. And when it comes to the AMSK, this patient has tender left wrist, bilateral ankles without erythema or swelling, and decreased strength with dorsiflexion or plantar flexion of bilateral ankles. When it comes to the neuro exam, from cranial nerve 12 to, from cranial nerve 2 to cranial nerve 12, it's intact. This patient also has decreased sensation to light touch in stocking and glove distribution, and decreased vibration in the feet and ankle bilaterally. And also, I'm gonna stop there, just that.
Okay, Rafa. I think, Promise, do you have like a question about the physical exam, or you were able to describe everything?
Oh no, I sent her the case. Sorry.
Oh, okay. Okay. Thank you so much. Well, guys, what do you think about a physical exam? Well, in the meantime, I think Mario has suggested about TB and how TB can explain these symptoms. Mario, can you share with us that amazing idea?
Yes, hi, can you hear me? I think my connection is not that stable.
Yeah, we can hear you perfectly.
Well, I was trying to tie together all the findings, and one thing that struck me was the food aversion and epigastric pain. And one hypothesis could be that there's a gastric TB associated with a gastric outlet obstruction causing these symptoms, and the other is there and chronic mesenteric ischemia causing the intestinal angina, or so-called intestinal angina, and that could be secondary to one of the vasculitis that had been talked about.
Yeah, definitely TB is as a hypothesis here. And I also think Fernand has like a question about how to differentiate between mononeuritis multiplex and peripheral neuropathy. Fernand, can you share with us your idea?
Yeah, I think that the neurological syndrome that we have, especially the distribution of the decreased sensation and the distal weaknesses, suggest to me that the peripheral nervous system is involved. And in general, peripheral neuropathy is symmetric and length dependent. So it starts in the toes and once it reaches probably the knees, you start having problems in your fingers. If you go by the book, in general, it's symmetric and progressive, but sometimes mononeuritis multiplex is hard to differentiate from it. It starts asymmetrically, and sometimes it starts in one limb, then moves to the other. It could start in motor fashion, then affects the sensory problem in the other limb. So it's more like sprinkled in the limbs. Based on this, I still don't know which one of the syndromes it is, but whatever this syndrome is, the nerve conduction studies will help. And this suggests to me that there's at least a medium to small size vessel involvement, because these are the vessels that feed the small nerves.
Thank you so much for now. I think it's also really nice about how to put everything together in thinking about this complex topic, how to differentiate these syndromes. But yeah, definitely in this case, it's kind of hard, as you said. Rafa, do you mind sharing with us the labs, maybe?
Yeah, so we have 2 more aliquots, including the labs right now. So the white blood count was 26.1, which is high. The hemoglobin was 12, which is low. The platelets were normal. When it comes to the differential, this patient had 61.5% of neutrophils and 25.9% of eosinophils, which is high. When it comes to the sodium, it was 133, potassium 3.8, chloride 97, the bicarb was 23, the BUN 34, the creatinine 1.72, and the glucose 124. His AST, ALT, total bilirubin were all normal. And there was an urinalysis that showed 1+ protein, moderate blood, and red blood cells. The urine eosinophils was 19%. The CK was 73, which is low. The CRP and the ESR were both high in the 100s, and the TSH was 1.14, which is normal. And to the end, this patient also had a HIV and acute hepatitis panel done. Both were negative. COVID-19 was also negative, and quantiferon gold was also negative. And that's the end of the aliquot.
Rafa, is the next aliquot will reveal the final diagnosis?
We have additional labs and imaging, and then it's the final diagnosis.
Thank you, Rafa. Well, I think the chat is speaking a lot about eGPA. As you said, eGPA earlier, how do you think all this additional data can support further this hypothesis?
Right. So, I mean, I thought about EGP again when we had the wheezes and we had the joint involvement, but I'm a bit confused about, I mean, why would there be decreased vibration in proprioception? Maybe because the vasculitis also involves the nerve. I mean, the small vessel vasculitis also involved the nerves. So maybe we can explain it with that. I was also very interested in the chat talking about amyloidosis, and it can definitely explain a lot of symptoms we have there, but I'm not sure. I think that amyloid presents at a later age, especially with so many signs symptoms, like somewhere like late 60s and late 70s. So maybe someone could just add on to that and explain. explain about that. Yeah, that's what I have right now.
Thank you so much, Aaron. That was really nice, and I totally agree. I think Arisha also was talking about how the eosinophils can support sugar stress now. Arisha, can you share with us that amazing idea?
Hi everyone. Yeah, since eosinophil was high and we are also having the neuropathy, so that among the vasculitis syndrome, I thought towards this Church-Ross. The amyloidosis, I also don't know much, like why amyloid might happen here. That's all. Thank you.
Thank you so much, Arisha, to you. And also, Kushal it wrote in the chat about strongyloides, enters the chat. Kushal, I think strongyloides is also one of my favorite parasites. Are you able to elaborate more your idea? If not, that's totally fine too.
Yeah, I was just thinking about it because of eosinophilia, but I think that EGPA would make much more sense because of possible mononeuritis multiplex. But strongyloides came to my mind because I was just reading a case on Twitter shared by ELID where a patient came from Africa and had eosinophilia, but patient also had heme malignancy and HLH, so was diagnosed with strongyloides. So I think it was like recency bias, but I think with this case, I would definitely thinking about EGPA.
Thank you so much, Kushal. Strongyloides is also one of the favorite topics here in the VMR as well as TB. So I think we don't actually know. It could be GPA, strongy, or a typical presentation of TB. So thank you so much, guys, for all your amazing pros. Ravi, what are you thinking?
Sorry, I had to pause a moment because I had to look to see if Ravi wasn't saying anything in the chat. Very similar. I'm going to share a couple of schemas with you guys. I think it's very rare for sinus patients to where'd it go? It's very rare for sinus patients to get a systemic disease. Once they do, the differential diagnosis, if you assume the sinus disease is not just an innocent bystander, is often one of these very limited differential diagnoses. Atopic disease with ABPA or aspirin exacerbated respiratory disease, immunodeficiency syndrome, certain infections, and as you all are pointing out, autoimmune disease. Now, why might you be prioritizing autoimmune disease? Because glomerulonephritis, which the urinalysis suggests, if it's systemic, it's almost always an autoimmune disease. And so I think the spotlight is here. The other pro that I think people are really focused on is the combination of eosinophilia and acute kidney injury. So what does that mean? What is it when somebody has eosinophilia and acute kidney injury? It's very tempting based on step one to see eosinophilia and AKI and say this is acute interstitial nephritis. But as you can see, there's a long differential diagnosis. And really the only glomerular causes. And why are we focusing on glomerulus? Because there's proteinuria and hematuria. The only glomerular causes are these two things. So if you go back to the sign, sorry, I closed, here we are. I closed it, I'm sorry. But if you go back to what are the systemic causes of sinusitis, if you filter it by glomerulonephritis, you really only get the ANCA-associated vasculitides. And when you layer on the eosinophilia, there's only one real answer. And I'll just say that what really filters the DDX here is the presence of signs of glomerular injury. Of all the things, glomerulonephritis is almost always autoimmune. 70% of it is ANCA. So what are the autoimmune diseases of the sinus? They're ANCA-associated and IgG4 disease. So here, in this case, is really a very good presentation for eGPA, as the chat is alluding to. I'll give the mic back to you, my friend.
Wow, Ravi, that was so educational. Thank you so much. I learned a lot. Rafa, could you tell us more about the case?
Okay, so this is the last article. This patient had a P count of 1 to 1,280, which is high. The C was negative. The C3 and C4 were both normal. And the 24-hour urine protein collection was high. And that's the end of the case.
Wow, I think that could explain all these things. Well, I think the chat is screaming a GPA already. So Drew, can you tell us more, please? And if you have like a problem representation, maybe in English, also that would be very nice.
All right, so sorry, I just had to finish up my my brunch. So this is a 55-year-old gentleman who with chronic, well, subacute left lower extremity pain and weakness, and chronic sinusitis, who on exam was found to have stocking glove peripheral neuropathy and distal weakness. And on labs and imaging was found to have glomerulonephritis, as well as a positive P ANCA and eosinophilia, which indicates that the final diagnosis for this case would be eosinophilic granulomatosis polyangiitis, or EGPA. And as Fernand says in the chat, yes, this is screaming EGPA. You do not need to do a kidney biopsy. We can just treat. So steroids for this would probably be steroids for him, and then probably put him on immunosuppressive therapy until things quiet down. This is an excellent case, and Rafa, thanks for presenting it. And I didn't catch who was the writer of the case. I know this was a HumanDX case, but to whoever they were, thanks so much for putting this case on HumanDX.
Thank you so much, Drew. Maria, do you happen to have like a problem representation maybe in Spanish? And maybe your favorite pearl also in Spanish too.
Sí, por supuesto. Bueno, tenemos a un paciente masculino de 55 años que se presenta con una historia de dolor en las extremidades y debilidad, asociado también a un rash doloroso que desapareció espontáneamente, y a historia de una neumonía atípica y de sinusitis recurrente. En el examen encontramos una neuropatía periférica y en los laboratorios encontramos una glomerulonefritis, eosinofilia, y se le hacen las pruebas correspondientes y también tiene un PANCA positivo, lo cual pues es muy sugestivo de, creo que ni lo puedo decir en español. ¿Cómo decimos EGPA in Spanish? I'm gonna go with like Church-Strauss and that's it, because that's just too long a name for me to say that in Spanish. Y creo que mi perla favorita fue siempre que estén pensando en vasculitis y no están muy seguros en dónde empezar, inician con la causa más mortal, que serían las vasculitis de grandes vasos. Si no encuentran nada ahí, pues piensen en vasculitis de medianos vasos, y si no encuentran nada ahí, pues piensen en vasculitis de pequeños vasos. De lo más mortal a pues también mortal, pero no tanto. That's it.
Sí, esa también fue mi perla favorita de Ravi. Definitivamente el matemático lo hace de nuevo. The mathematician strikes again. I think also for ending this episode, Daniela has also a prominent presentation in Portuguese. Daniela, can you share with us?
Oh, yeah. Hi. A gente vai falar em português agora. Então, no caso de hoje, nós tivemos um homem de 55 anos que apresentou dor e fraqueza em membro inferior esquerdo e sinusite crônica. Durante os exames foi identificada neuropatia periférica e fraqueza distal, e nos exames complementares foi identificado sinais de glomerulonefrite, eosinofilia e o Pianca positivo. That's it. That's
Thank you so much, Daniela. And finally, for any final thoughts, Ravi, and maybe we can then pass the mic to Maria for the teaching points.
I am just so impressed with everyone who's done this for the first time. You know, we've had almost every CP Solvers team member. I'm looking at you, Rafa, facilitate this, and it's just incredible to me how incredibly smart everyone is. And a special shout out to you, my friend, for seamlessly facilitating such a complicated case and getting so many different people to share their opinion. I really, really enjoyed the ride. It's nice. I'm just sitting back here playing with schemas and listening to all these wonderful reflections. I also wanted to shout out Promise, who crushed it on her first ever scribing. It's really, really, really well done, Promise. And thank you, Gabrielle. Thank you, Promise. Thank you, everybody. And we'll, of course, end with a Maria masterclass with the teaching point.
Thank you. It's going to be a masterclass because I recapitulated the teaching points from everybody in the chat. And Gabrielle and Ravi, this was an amazing case. We started out with weakness, and always, you know, weakness is one of those things that you really have to define because it can mean anything or nothing. So think if it's true weakness or just asthenia, and then try to characterize it. Where is it starting? Where is it going? And if you can, try to divide it between central nervous system and peripheral nervous system. And if you can go a step further, try to see if it has characteristics in nerve, muscle, or the neuromuscular junction. With leg, you know, everybody has experienced leg pain, so you really have to look for those red flags that can compromise the limb or the person. So try to see if there's a history of trauma, or does they have ischemia signs that can indicate vascular trauma or compartment syndrome, and always think of infections that can compromise a leg. And then we had this really interesting rash, and with rash and a lot of accompanying signs, whether they're like in any sort of system, rash plus anything else, always try to think of vasculitis. Think of the presentations and also the triggers and risk factors for them. Infections such as mycoplasma and great mimickers like TB. We can never have a GVMR without somebody mentioning TB, which I love. And then try to narrow it down and do Venn diagrams with everything, which I think we've had some really good Venn diagrams today. So for vascular and neurology, it's usually centering around the CNS with strokes, but if PNS, that's not so common. And things like mononeuritis multiplex, it's much more rare, but you can exclude large vessel problems first, as I said in Spanish, because those are going to be the most morbid ones through embolism. And if you don't have anything there, go to medium vessels and then small vessels, because the larger the vessel, the most problematic. And good thing is that, you know, we have vessels everywhere, so you really can have signs and symptoms of any disease everywhere. Just because they have things in the skin doesn't necessarily mean it's small vessels. Large vessels through embolism can cause like skin problems, for example. And then we had like this really good illness group for EGPA. Always consider it if you have like late onset asthma, eosinophilia, and small vessel vasculitis. There are small vessels literally everywhere. So you can have GI, neuro, pulm, cardio, renal manifestations. And for the DDX of EGPA, which you have to consider, it can be fungal or parasitic infections or eosinophilia syndromes. And if you have like eosinophilia and acute kidney injury, don't rush to think it's EGPA only. But then there are certainly other signs that can support your theory, such as sinus and systemic diseases, which is also a really good Venn diagram that Robbie shares. So with sinus and systemic diseases, it can mean the sinusitis is just like bystander and not very consequential. It can mean a atopic problem, an immunodeficiency problem, and an autoimmune. But when you put everything together, such as glomerulonephritis, eosinophilia, asthma, and multiple organ involvements, and a PNCA positive, it really makes a good case for EGPA. So hope you liked it. I really enjoyed the case, and thank you for letting me do teaching points.
Amazing recap as always, Maria. Thank you so much, guys, for connecting in, and see you tomorrow.